Hi, my name is Jennie Hall, and I'm one of the third-year plastic surgery residents here at Curling Clinic, and I'm going to be talking about wrist arthritis. So wrist arthritis is a relatively common pathology affecting almost 14% of the US population. Most commonly, it's a result of a prior trauma. However, you can have a primary osteoarthritis as well. It's also very common in rheumatoid arthritis patients, and over 50% of rheumatoid patients will have wrist involvement by 2 years, and that increases to 90% at 10 years. So there are different etiologies of wrist arthritis. You can have a degenerative process, mostly primary osteoarthritis affecting usually the midcarpal joints. And you can also develop this as a result of a prior trauma, which leads to a predictable pattern of changes of arthritis, described as slack, snack, or DRUJ arthrosis. It can also be an inflammatory process as seen in rheumatoid arthritis, psoriatic arthritis, or lupus. You can have congenital causes such as Maitland's deformity, which is a deformity that affects the growth plate of the radius, which causes deficient radial growth and ultimately leads to ulnar compaction and subsequent arthritic changes. And you can also develop arthritis after avascular necrosis of the lunate or scaphoid. So looking at the two most common causes being osteoarthritis and rheumatoid arthritis, they do have different underlying pathologies that cause them. So osteoarthritis is really a result of aging and mechanical load that leads to cartilage degeneration, versus rheumatoid arthritis is an interplay of immune cells, cytokines, and antibodies that result in the formation of a destructive pannus that will ultimately destroy soft tissue such as ligaments and tendons, and as well as cartilage and bone. And both of these will have joint space narrowing on x-rays. However, they do differ a little as well. So in osteoarthritis, you will see bone spurs or osteophytes, whereas in rheumatoid arthritis, you're more likely to see bone erosion of the joints. And then also in rheumatoid arthritis, you're more likely to see the pannus or synovial hypertrophy on imaging. Regardless of how or the underlying cause of why this happens, both of these disease processes alter the joint, which then subsequently will alter the kinematics of the wrist. And this leads to pain and stiffness of the joint. So these patients often present to clinic with complaints of pain, crepitus, swelling, decreased range of motion, and even weakness of the wrist. And they will often be having functional impairment by the time that they will present to a hand clinic. And when you are meeting them, you want to ask them if they've had any prior traumatic injuries or fractures that could have potentially led to these arthritic changes, or ask them about any systemic diseases that they have, especially autoimmune ones, which might point you more to an inflammatory type arthritis, such as rheumatoid arthritis. And then, of course, you always want to ask them about their occupation and what kind of daily functions they're doing to assess how much load and impact that their hands have on them. So you want to always do a physical exam, including complete motor and sensory exam. You want to look at the hands, look for any scars, which may indicate that they've had a prior surgery or trauma, look for swelling, effusions, masses, assess their range of motion and grip strength, and then you can use loading to localize points of maximal tenderness, which could guide you to which exact area and joint might be affected. Again, doing different provocative maneuvers. And then you also want to look for any joint instability as well. So imaging is going to be used in the workup of these patients. Usually you just need to do some x-rays. So you want to do a PA, lateral, oblique views of these, and then also of the specific joint that might be affected based on your physical exam. Occasionally you could consider getting a CT scan if you want to get a better look at the bone quality and joint disease, or could consider an MRI more so if you're looking to evaluate for vascularity or bone marrow changes. But oftentimes the radiographs will be sufficient. And it's important to just keep in mind that we are treating the patient and not the radiograph. Oftentimes these patients will have diffuse arthritic changes on x-ray, or arthritic changes not where they're having pain. And so it's just important to really correlate to what you find on an exam and treating just where they're having pain. So most commonly, especially mild and moderate arthritis of the wrist, you're going to manage this non-operatively, and you're going to do that with heat. So you could use warm water, or even paraffin wax has been shown to help with pain. Also, different pain medications such as Tylenol, NSAIDs, or Voltaren gel can be helpful. And then you can try nocturnal or resting splints to help, as well as get them into a hand therapist to work on range of motion exercises and strengthening their muscles to help reduce the pain. And then you can try steroid injections as well. This can be helpful to reduce pain, but it's not going to necessarily treat the disease process or continuation of the process. So it's really just for symptomatic control. If patients fail non-operative management or have severe disease is when we start talking about operative interventions. And so when we're considering this, you want to take into account the age of the patient, what they do for work, how much functional demands they place on their hands and wrists, and also any underlying systemic diseases. And some basic principles you want to abide to when you do surgery for wrist arthritis is you want to manage each involved joint. And then you really want to counsel the patient that this surgery is to improve their pain. And at the price of that, they will be trading a loss of strength and motion for that. And you just really want to make sure that patients are aware of that. And different options that we have here are resection arthroplasty, implant arthroplasty, or partial arthrodesis. And so really the goal of these surgeries is to have a pain-free, stable, and functional wrist. So looking at a little bit of anatomy. So the wrist motion that is important that the wrist does is flexion, extension, radial ulnar deviation, and pronation and supination. And normal range of motion, flexion, you should have 65 degrees, but you actually only need 10 degrees to be functional. For extension, 55 degrees is normal, but you need 35% to be functional. So again, extension is more important for function than flexion. And then radial deviation, 15 degrees is normal. Again, you only need about 10 degrees to be functional. And for ulnar deviation, 35 degrees is normal and 15% is needed to be functional. So ulnar deviation a little bit more important. And really, you're never doing those motions alone. So the summation of those motions is known as the dart thrower's motion, which is where you'll have radial deviation extension to ulnar deviation with a little bit of flexion. So looking at the wrist joint itself, so there are no muscles or tendons that insert onto the carpus, and it's stabilized through a complex ligamentous support. And these can be extrinsic or intrinsic ligaments. And some of the most important ligaments as far as this discussion we'll go over. So there's the scapholunate ligament or the SL ligament. And this is the most commonly injured ligament connecting the scapholunate. And there's both a volar and dorsal component to that ligament. And it's important to realize that that dorsal component is actually the stronger one compared to the volar component, which you can see at the bottom of the screen there. Another ligament is the lunate trapezial ligament or LT ligament. And in comparison, this one actually has the volar aspect of the ligament being the stronger component compared to the dorsal. So SL ligament, the dorsal component stronger versus LT, the volar is stronger. And then the other ligament to talk about is the radioscaphocapitate or RSC ligament. And this ligament is located at the volar radial side of the wrist. And it's important because it is going to allow the wrist to prevent ulnar translation of the carpus. So looking at the wrist kinematics, so really the ligaments all come together to allow the proximal and distal rows to move in a coordinated fashion. And there are the proximal and distal row really are spanned by the scaphoid. So although the scaphoid's in the distal row, it also makes a connection and almost acts as a crank between the two rows to help guide motion in conjunction with the ligaments. So axial loading can be when it's applied to the wrist, it's translated oftentimes through that capitate, and then it results in flexion of the scaphoid joint and then extension of the trapezial joint. And because of the balance of all of the ligaments in the wrist, although these are opposing forces, the ligaments hold it together so that the wrist is still able to act as one unit. And so when you have radial deviation, what happens is there is the axial load is compressed onto the scaphoid, and the scaphoid will then start to flex, and therefore bringing the rest of the carpus with it. In contrast, ulnar deviation, the axial load is translated to the triquetrum, and that allows the triquetrum to extend, and the rest of the proximal row and wrist will follow in conjunction. And so here is just a nice description and visualization of what happens here. So when that force is applied, the scaphoid is going to flex and the triquetrum is going to extend, which is really the key to a lot of what happens with wrist kinematics. So there are, depending on injuries that can happen with the wrist, you get kind of two main deformities. You can have a dorsal intercalated segment instability, or a DZ deformity. And this happens when there is a SL ligament disruption. And because that ligament is no longer holding the scaphoid and lunate together, when there's an axial load applied to the wrist, the scaphoid is going to do what it naturally wants to do. It's going to flex, and the triquetrum is going to extend. And since the lunate is still only attached to the triquetrum, it's going to follow it and extend as well. And this leads to increase in the SL angle greater than 60. Normal is 30 to 60 degrees. And if this is untreated, it can lead to slack wrist, which we'll get into more detail here shortly. And then kind of putting this in comparison to volar intercalated segment instability, or VZ deformity. This is where you have disruption of the LT ligament. And in this case, you have the scaphoid still wanting to do what it wants to do, which is flex. And since the scaphoid is attached to the lunate, however, the triquetrum is not attached to the lunate is going to follow the scaphoid in this situation. So the scaphoid and lunate will flex, and the triquetrum will extend. And because of that, the lunate doesn't have the counter tension from the extension of the triquetrum. You have a decrease in the SL ligament, or the SL angle, to less than 30 degrees. So again, here is a nice demonstration of what exactly is happening here. So in that SL or ligament injury causing the DZ deformity, you get disruption of the ligament, and then you get the scaphoid flexing, lunate triquetrum extending. And you can see that the capitate follows the lunate, and you'll get a dorsal subluxation of that, versus the VZ deformities from the LT disruption. And here you'll have the extension of the triquetrum and flexion of the scaphoid and lunate, and the capitate again follows that lunate too, and you get that volar subluxation of that joint. So we'll start by talking about the scapholunate advanced collapse, or slack wrist. So again, this is a pattern of degenerative arthritis that is a consequence of chronic dissociation of the scaphoid and lunate. So oftentimes seen in chronic SL injuries that lead to that DZ deformity we were just talking about. So you'll get flexion of the scaphoid and extension of the lunate and triquetrum. And on x-rays, you can diagnose this by seeing an SL angle greater than 60. And again, so this leads to a predictable progression of arthritis involving the midcarpal and radiocarpal joints. And it starts at the radioscaphoid joint and then progresses to the capitolunate joint. So the Wattsman classification is used to describe the severity of slack wrist. So in stage 1, you will have arthritis between the scaphoid and the radial styloid. In stage 2, you will also develop arthritis now between the entire scaphoid facet of the radius and the scaphoid. And then in stage 3, that's when you then develop arthritis between the capitate and the lunate. And traditionally, when this was first described, one of the main things was that the radiolunate joint was spared in this classification. However, there is debate over this, since there has been several descriptions of the radiolunate joint being involved in severe slack wrist. So that's kind of up to debate. Some people will describe that as stage 4, but typically and standardly, the radiolunate joint is spared, which if it is affected, you often will think that another disease process could be happening. But this classification is helpful because it helps guide treatment. So in stage 1, where you just have the radiostyloid affected, you can do a radiostyloidectomy. In stage 2, where you have the entire scaphoid facet, you can either do a proximal row corpectomy or four-corner fusion. And for stage 3 disease, that's where you start to have the involvement of the capitate and lunate. That's where you're going to either do a four-corner fusion or total wrist fusion. So here is a video here showing exactly what's happening here, and is a nice depiction of how this happens. So you get the disruption of the SL ligaments and then attenuation of the other bones, which result in flexion of the scaphoid, extension of the lunate interquetrum. And then as you see, that capitate starts to settle down over time and dorsally subluxes over the lunate, which is how you get that capital lunate involvement eventually. So these patients with slack wrist often will come in difficulty bearing weight across the wrist. They'll have pain in region of the SL interval and progressive weakness over time, as well as stiffness. And so on exam, they'll have tenderness dorsally over the SL ligament, decreased range of motion. They could have weak grip. And then if in early disease stages, they can have a positive Wattsman scaphoid shift test, which we'll talk about in the next slide here. On imaging, on the PA view, you'll see a greater than 3 millimeter diastasis between the scaphoid and lunate, which you can see in the top left picture there. And then you can also have a scaphoid cortical ring sign, and that's just because the scaphoid's flexed, and so the distal aspect is overlying the proximal axis part of the scaphoid, causing that ring to be seen. And then you'll also see the standard arthritic changes per the Wattsman classification. And you can also get a lateral view, and that will show you the DZ deformity and subluxation of the capitate dorsally over the lunate. So the Wattsman scaphoid shift test, again, you can see this in SL injuries acutely and in early slack wrist, less likely to be positive and with chronic changes. But this test is done by you will ulnarly deviate the patient's wrist. You'll apply dorsal pressure over the scaphoid, and then you will radially deviate their hand. And what this does, it will flex the scaphoid, and then because the SL ligament is out, your thumb is going to dorsally sublux the proximal scaphoid over the radius. And then when you release your thumb, it'll plunk back into that place. So you'll feel that thump as it comes back into the normal facet. So we'll talk a little bit about treatment for slack wrist. So you can do wrist denervation procedures. Specifically, you would transect the PIN or AIN. And this is a procedure that can be done for stage 1 disease or combined with other procedures for more advanced arthritis. And you're able to do this because the PIN, which is the distal branch of the radial nerve, and the AIN, which is a distal branch of the median nerve, do not have any muscle innervations and just provide a sensation to the wrist capsule. So you can transect this without any functional loss. And you can do a bupivacaine block to simulate what their pain relief will be with this procedure, to give the patients an idea of if they'd want to pursue with this. The advantage of this is it's minimally invasive with very minimal downtime compared to some of these other procedures. And this can be done by access to both of those nerves via a 3 to 5 centimeter proximally to the dorsal wrist is how you can get access. So you can also do a radial styloidectomy for stage 1 disease. And the goal of this is to prevent impingement between the proximal scaphoid and the radial styloid. And when you're doing this procedure, you want to make sure that you preserve those radial sensory nerves as you get down to there. And then you also want to be careful of the RSC ligament, which is in that location as well. And this can be done as an open or arthroscopic procedure. And then there are different osteotomies that have been described as well. Next, you can do a proximal row carpectomy or PRC, and this is indicated in stage 2 slack wrist. And this would be contraindicated in a couple scenarios, specifically if there's stage 3 disease. And this is due to the fact that in this surgery, you're taking out the proximal row, so the scapholunate interquetrum, and as a result, the capitate is going to be what articulates with the radius now. And so if you have arthritic changes of the capitate and lunate, which is stage 3 disease, you're putting an arthritic bone onto that radius, which could result in problems down the road. and continuation of pain. And then the other contraindication would be if you have injury or an incompetent RSC ligament. And again, that ligament is there to stabilize the wrist and prevents that ulnar translation of the wrist. So if it's injured, you will still get that ulnar translation would not be a good option here. So this surgery is one of the more common ones that is done. However, it has been found that after 10 years, some patients will have evidence of degradation of the radiocapitate interface. However, their wrist motion and grip strength is still preserved. And then so long-term outcomes of the PRC have been shown to be inferior to four-corner fusion, which we'll talk about next, in patients less than 40. And again, that kind of goes in line with the fact that they start to see these arthritic changes after 10 years. So next you can do a scaphoid excision and four-corner fusion. So this is indicated in both stage 2 and 3 slack wrist. And in this surgery, you will remove the scaphoid and then you fuse the lunate, triquetrum, capitate, and hamate. And then you will, the joint surfaces of those bones are decorticated, fused, and then filled with bone graft. And there's different techniques for this. For fixation, you can use K-wires, IM screws, staples, circular plates. And this actually can be done open or arthroscopically. And then the idea behind this surgery is that you preserve the lunate and distal radius articulation, which is a natural articulation that happens, and that's what's guiding all the wrist motion in this situation. And when you're doing the surgery, you just want to be careful that when you're excising the scaphoid, you want to preserve the RSC ligament again, because it's going to be running right in that area. And one drawback of this surgery is that it does usually require 6 weeks immobilization, which is longer than a PRC would require. However, it's thought that there is shorter downtime with arthroscopic procedures. Another drawback is that it has been thought that there is higher complications, specifically that you have non-union as high as 63%. Although it has been described that this is more likely to happen specifically with the dorsal circular plates and just how it's designed. They think that the screw placement is leading to damage of the blood supply of the scaphoid and lunate, which is then resulting in non-union. So both PRC and four-corner fusion can be used to treat stage 2 slack wrist. And there's a lot of debate in the literature about which one is better and when you should use one over the other. And there was a systematic review by Pierre-Emmanuel Chamans in 2022, which was done, and they showed that there was no difference in grip strength or rate of conversion to total wrist arthrodesis or changes in pain dash scores. And so what they also showed is that the PRC was superior in a couple of aspects. They showed that it did have better range of motion after the surgery. Partially, this could be because there is shorter immobilization periods, so they're able to move quicker. And also, the four-corner fusion is more likely to have impingement since you're having to realign the bones and putting in those fixation devices. The PRC was also shown to have a lower complications. And again, the four-corner fusion is more technically difficult and you have to get the bones aligned up. So it makes sense. That's what they were saying is probably the reason for lower complications. And they also subsequently showed the PRC had lower reoperation rates. And one of the pros for the four-corner fusion that is debated or talked about is that the four-corner fusion has a lower risk of arthritic degeneration. The systematic review did not demonstrate that. However, the idea behind this is, again, that the four-corner fusion relies on the lunate radius articulation, which is a normal natural joint, and preservation of the triquetrum as well. So there is a larger joint surface that the wrist motion is all impacting its forces onto, versus the proximal PRC relies on the capitate and the radius articulation, and only that one bone that is not designed to naturally be there. So the thought is that you can get degenerative wear from that joint more so with the PRC compared to the four-corner fusion. So again, how do we decide when to do a PRC versus four-corner fusion? And again, this is really just for type 2 slack wrist. So again, so if you have capital lunate arthritis, that's going to guide you to do a four-corner fusion. Again, that's just because the capitate has arthritic changes, so you don't want that being your point of articulation like it is in the PRC. And then there was a paper that went over to look what positive predictors were shown to have improved PRC outcomes. And what they found were patients over 40 years old were shown to have better outcomes with PRCs. And again, that's the same idea coming back to that there's potentially more long-term arthritic changes associated with the PRC. So if they're older, they have less axial load constantly applied to that. And again, likely, so non-manual labors, same results. And then also, interestingly, they found that a type 1 capitate predicted a better PRC outcome. And these types of capitates were described in a separate paper and used here. So the type 1 capitate was flat, which is more similar to how the lunate is shaped. And the lunate facet of the radius is more flat. So with this flat type, there's a larger surface area that come together. And so the axial load is dispersed over that entire surface. So it's thought that there's a better displacement of all that force versus type 2 is more of a sphere shape. So you're going to have a smaller surface area making that articulation and a less natural surface compared to what the lunate would be. And then the V shape is really much more pointy. So again, all of that axial load is applied to that one point. So it makes sense that the anatomy of a capitate with a flat surface like the lunate, which has a larger surface area, could do better potentially with a PRC. So looking at other options, so you can do a total wrist arthrodesis, and this would be indicated in stage 3 disease or pancarpal arthritis or a salvage procedure. This is a good option. It has reliable relief of pain, but at the expense of decreasing wrist range of motion. However, you do maintain grip strength. In this surgery, the articular surfaces of the radiocarpal, midcarpal, and third CMC joint are denuded and filled with bone graft, and then use a compression plate that spans the dorsal radius and third metacarpal. So you can also do a total wrist arthroplasty, and this would be indicated in late stages of slack or in older patients with low functional demands. And you can also do this as an option following failed limited arthrodesis or if there is avascular carpal bone necrosis. And here there are many different implants that are available for use. And you can anticipate about 40 degrees of extension, 20 degrees of flexion, 10 degrees of radial deviation, and 15 degrees of ulnar deviation. The problem with this is it has been shown there's high complication rates with this. You'll often get loosening and dislocation. So next we will talk about scaphoid non-union advanced collapse or SNAC wrist. So this is a progressive pattern of degenerative arthritis that results from chronic scaphoid non-union. And the proximal scaphoid will remain attached to the lunate still. And so the distal scaphoid will flex. And in this disease, you will have early arthritis between the radial styloid and the distal scaphoid. And it's been shown that prognosis is worse if non-union is greater than 5 years or if you have proximal pole necrosis. So these patients will often present with reduced grip and pinch strength. They'll have reduced extension and radial deviation and progressive wrist pain and instability. And on exam, you'll find localized tenderness over the radioscaphoid articulation. You'll have reduced wrist extension and radial deviation. So again, there is a classification description to describe the severity and stages of SNAC wrist. So in stage 1, you have arthritis localized to the radial side of the scaphoid and the radial styloid. And then in stage 2, as it progresses, you will also have arthritis of the scaphocapitate joint. And then in stage 3, you have the addition of periscaphoid arthrosis progressing to capital lunate. And then so different managements for snack wrist. So it's very similar to slack wrist with a few differences. So you can do a radial styloidectomy for stage 1 snack wrist. This is often combined with other procedures as well. One difference is you can do a distal scaphoid resection arthroplasty for stage 1 snack wrist as well. So in this situation, stage 1, you would have the SL ligament still intact to the proximal pole. So because you still have that connection between the scaphoid and lunate, you are able to take out that distal segment. However, this would be contraindicated if you had a DZ deformity, because the DZ deformity is a result of an SL injury or tear. So that SL ligament is not intact. And so you wouldn't want to take out the just the distal aspect of the scaphoid, because it wouldn't treat the underlying problem there. And this is a good option. It's technically simple, minimal downtime, and a high satisfaction rate. And you will have significant improvement in grip strength and pain, although it won't have much improvement of range of motion with this procedures. So like slack wrist, for snack wrist, you can do a PRC, which would be indicated in stage 1 or stage 2. You couldn't do it in stage 3 as long as there's minimal to no capital lunate disease. And you can do this in relatively low demand patients, again, like we were talking about for slack wrist, and is less favorable in patients less than 40 and heavy laborers, again, just because there's that risk of potentially developing arthritis of that joint later on. You can also do a 4-corner fusion, again, indicated in stage 2 or 3 snack wrist, or total wrist arthrodesis, again, for stage 2 or 3 snack wrist. And that would be really your salvage option for other failed arthroplasties or limited arthrodesises. So another option is you could do a medial femoral trochlear osteocartilaginous flap. And this is where you will take a free flap from the medial trochlea and then use that to replace the proximal portion of the scaphoid. So this would be indicated really if there's a difficult proximal pole scaphoid fracture in only early stage 1 snack wrist. So you don't want to have a lot of arthritic changes, because we are not treating those arthritic changes. We are just getting rid of that devascularized proximal segment. And you're able to do this because you're just replacing that proximal pole and you're preserving the distal SL ligament, which is why you don't get instability of the wrist after doing this. And this is a good option because the medial trochlea provides an anatomically analogous convex segment of cartilage-bearing bone, very similar in design of the proximal scaphoid. And so the pedicle of this flap is the transverse branch of the descending genicular artery, and then you would use your recipient vessel would be the radial artery in this situation. And they have shown to have good outcomes. They've had high rates of union, good range of motion, and it will resolve and improve pain. And so here is just a case example, so where it shows the fracture of the scaphoid, and then here you see the flap, and then you can use a pre-designed template to carve out exactly the flap that you would need, and then you can see the pedicle there. Here you see the resected proximal aspect of the scaphoid, and then you slip that flap exactly into there in that shape that you want, and then you put a pin in it, and it usually heals up nicely. So next we'll talk about scaphotrapezial or SAT arthritis. So STT arthritis is the second most common location of wrist arthritis, affecting about 16% of the US population. It can be seen and associated with pseudogout or thumb CMC arthritis. And you get instability of the STG joint or within the carpus. It can from DZ or mid-carpal instability, and this leads to cartilage erosion and development of arthritis. These patients will present often with sharp wrist pain, especially with gripping, radial deviation, reduced grip strength, and you can have an FCR tendonitis because of where the FCR is inserting is running right through the space. And so on physical exam, you can often find painful bony prominences distal to the radioscaphoid joint. Range of motion is often preserved. Pain along the STT articulation with radial wrist deviation. And often they will have a negative grind test, and that's how you can differentiate this from CMC arthritis. So on imaging, you should include STT views and full ulnar and radial deviation. And you will see STT joint narrowing and osteophytes. And the classification here that is used is the White classification. So in stage 1 disease, you'll have joint space narrowing. In stage 2 disease, you'll also develop cyst-like lucencies, plus or minus osteophytes. And then in stage 3, you have complete joint space obliteration with bone-on-bone contact. So treatment options for these patients include distal scaphoid excision. Patients who, this is a good option if they want to preserve range of motions and avoid a long immobilization, since this is a less invasive or involved procedure. And what it involves is just excision of that arthritic articulation, and it can be done either via volar or dorsal approach, or it can be done arthroscopically as well. And the issue with this is by removing that distal segment, you could be removing some of the SL ligament and weakening that ligament, which could result in a DZ deformity in the future. Another option is STT arthrodesis, which is ideal for young, heavy laborers. Contraindications include pre-existing radioscaphoid arthrosis, and is less ideal if the scaphoid is highly mobile. And that's really the reason why you get those radial and ulnar deviation X-ray views, because you want to see how much that scaphoid is moving around, because you're not fixing that articulation with the radius, so you don't want to develop an arthritis in there in the future. And this is often done in conjunction with the radiostyloidectomy, again, to just avoid the radiostyloid arthritic changes. And there are several different fixation techniques that can be used, including K-wires, headless compression screws, staples, or circular plates. Another option is a pyrocarbon implant arthroplasty. And this is done following distal scaphoid resection, and then you place a scaphoid trapezial interpositional implant. And here again, you just want to make sure you preserve the ST and SC ligaments to prevent any future DZ deformities. And again, this is going to be contraindicated in the presence of a basilar joint arthritis, again, because you're not addressing that joint arthritis. So next we'll talk about distal radial ulnar joint arthritis, or DRUJ arthritis. So this can be caused commonly after a trauma, specifically usually a distal radius fracture. It can also be a result of an inflammatory process commonly seen in rheumatoid arthritis, or it can be from ulnocarpal abutment syndrome. And these patients will present with pain, stiffness, swelling, decreased grip strength. And then on physical exam, they'll have point tenderness over the DRUJ, and they'll have pain exacerbated by forearm rotation and joint compression. And then you also have DRUJ instability and crepitus, so you can hold the DRUJ together and then pronate the wrist, and then you will feel that potential crepitus or instability. So on imaging, early radiographic findings occur over the proximal joint with sparing of the sigmoid notch. And then you can get osteophytes often located along the proximal ulnar head. And then you will also have evidence of distal radius fraction non-union or malalignment if that's the underlying cause, or you can look for ulnar positive variants, which could be another cause of DRUJ. So these imaging modalities can help you differentiate what is the cause of the arthritis. So looking at ulnocarpal abutment syndrome, this is a common cause of ulnar-sided wrist pain, and it's due to a longer ulna compared to the radial head, and then that longer ulnar side of the wrist causes excess impact stress between the ulnar and the lunate. And this is associated with positive ulnar variants. Again, it's just longer, and it can be caused by SL dissociation TFCC or lunoquetral ligament tears, or it can be caused by radial shortening from previous fractures. And again, you'll notice this on X-rays showing positive ulnar variants and sclerosis of the lunated ulnar head. And the operative intervention here is really just the same as DRUJ arthritis, which we'll get into now. So you can do the DARA procedure, and this is where you do a distal resection of the ulnar head. And this is a good option for low demand patients with severe DRUJ or ulnar impaction syndrome. And what you do is you just make a transverse osteotomy at the proximal margin of the sigmoid notch. And then you can then do various different procedures to stabilize the proximal stump of the ulna. So you can use the FCU, ECU, or PQ have all been described. A hemiresection interposition arthroplasty is similar to the DARA procedure, but the idea is that you are just resecting a smaller portion of that ulnar head. And the point of that is the idea is that you want to improve the instability that was often associated with the DARA procedure. Because you are going to here, since you're removing a smaller segment, you maintain the TFCC and the ulnocarpal ligaments as well. So another procedure that can be done is the Save-Kapanji procedure. And this is a DRUJ arthrodesis with creation of a proximal pseudoarthrosis. So as you can see here on the right, these imaging, so you leave the ulnar head, you make that osteotomy there to remove that segment, and then you will put wires or screws into the radial and ulnar where you want it. And this is ideal for rheumatoid arthritis patients when they have ulnar carpus, which we'll talk about in a little bit, because it prevents ulnar translation. And this can be done using fixation via screws or K-wires, and FCU tenodesis can be used to stabilize the proximal ulnar stump. You can also do a ulnar head implant arthroplasty, and this is going to be indicated for radial ulnar impingement following failed partial or complete distal ulnar resections. And again, there have been many different implants and techniques described to do this. These are both going to be salvage procedures that can be done. So you can do a one bone forearm. So this is just where you're going to fuse the radius and the remaining ulna. And it's very reliable, helps with pain relief, but the expense is that you are going to completely lose the loss of forearm motion. And you can also do a wide ulnar resection, also a salvage procedure, subperiosteal resection of 25 to 30% of the ulnar length. And again, this is going to be contraindicated in previous traumatic disruption of the IO membrane. So moving on to piezotriquetral arthritis. So this is a relatively uncommon arthritis. You will see joints, the joint space is not normally seen on normal x-rays, so you have to get special imaging because the joint is best visualized with the wrist and 30 degrees of supination. So if you're suspicious of this, you want to get that specific view. And these patients will often present with chronic ulnar wrist pain. And then treatment options would be if they just had piezotriquetral arthritis in isolation would be to perform a piezoform excision. So we will quickly talk about rheumatoid arthritis. This could be a talk of its own, but we're just going to specifically talk about how it affects the wrist. So rheumatoid arthritis affects females more than males, usually 30 to 50 years of age, and 70% of these patients will have hand involvement. And oftentimes these patients will present first with carpal tunnel. So rheumatoid arthritis is diagnosed with a constellation of symptoms and labs. There's no one simple finding or one simple lab test that will diagnose it. So combination of morning stiffness, arthritis in 3 or more joints, arthritis in the hands, symmetrical involvement, rheumatoid nodules, and then for labs, they might have rheumatoid factor, although it's not very sensitive. Anti-CCP is the most specific lab finding. ANA is sensitive but not specific. Then they'll have elevated inflammation markers. And then you'll also see the typical radiographic findings of rheumatoid arthritis. So non-surgical treatment is the mainstay for rheumatoid arthritis patients. NSAIDs and steroids are very commonly used. However, they are more for symptomatic control and they don't actually alter the course of the disease. Since the advent of DMARDs, it has actually greatly improved the treatment of rheumatoid arthritis and has decreased the amount of reconstructive hand surgeries because these DMARDs alter and arrest the course of disease. And it's important to just remember that before you do any surgery on rheumatoid patients, you should make sure that they've had at least 6 to 12 months of medical management first. And so you can consider doing surgery for these patients when they're having functional, debilitating, and painful deformities that are unresponsive to conservative treatment. And kind of the general principles here are that we are treating the painful joints. We want to improve function, slow progression, prevent loss of function, and improve appearance. So specifically, rheumatoid arthritis of the wrist progresses in a predictable pattern, and early sites of involvement include the scaphoid waist, the ulnar styloid or head, the radiocarpal ligaments, and then later involvement areas are going to be the radiocarpal and midcarpal. You can have dislocation of the DRUJ with radius displacing volarly and the carpus displacing ulnarly. And then you can also have dorsal subluxation of the ulna with carpal subluxation, and that's called caput ulna. Also here in rheumatoid arthritis, you have these joint deformities that are going to negatively affect the tendon and muscle bellies, resulting in the Z collapse. And oftentimes the proximal joints are then going to worsen the distal joints. So that's why it's important in these patients, if you're going to operate on them, you want to start proximally and then go distally. And then tendons may also be damaged by destructive tenosynovitis. And again, so it's just that interplay of all of these structures being involved in worsening the deformities. So you can do a synovectomy of the radiocarpal joint and the DRUJ in these patients. It's considered preventative in early disease, or it can be combined with other procedures at later stages. And again, you can do this in either a dorsal or volar approach, depending what you want access to. So you can do different treatments. So the treatment for DRUJ arthritis in rheumatoid patients is very similar to when you have DRUJ arthritis of other etiologies. You can do a distal ulna or excision with TFCC reconstruction. And that's just very important to do in these patients because in rheumatoid arthritis, you get the carpal supination, and then you want to make sure you just really stabilize the distal ulna. You can also do a Save-Kapandji procedure. And again, you want to stabilize the ulna to the radius, and that prevents the ulnar translocation associated with rheumatoid arthritis. You can also do different radiocarpal reconstructive procedures. So you can do a radiolunate arthrodesis, and then you can also do a radioscaphoid arthrodesis, depending on what is involved. You can consider doing a total wrist fusion. This can be done with plates or IM screws, and this would be considered when there's significant deformity and instability of the DRUJ, or if there's advanced joint destruction, poor extensor function, or poor bone stock. And then the other option would be a total wrist arthroplasty. And this is an important option for patients with advanced rheumatoid arthritis seeking preservation of motion. And that is it. Here are my references. Thank you for listening.